Hi group, welcome to our lecture today on cardiorespiratory and metabolic health. And this week our content moves to address cardiovascular and also metabolic consequences of sedentary behaviors, as well as evidence that really demonstrates the importance of avoiding physical inactivity. And if you remember last chapters, we learned about public health. So moving from this concept of treating the individual and looking at trends within large populations. And so the purpose of really presenting this specific chapter right now, chapter 5 on cardiorespiratory and metabolic health, is to really understand the trends that are occurring within a large population in regards to these specific metabolic health issues. And as we begin learning in this chapter, we first clarify the reason we discuss cardiorespiratory and metabolic health issues together is because their signs and symptoms are so very similar. And usually if a person has metabolic issues, they also more than likely have some sort of cardiovascular issue as well. So a lot of times we'll see the individuals have several, if not many types of metabolic disease or dysfunction that all stem from inactivity. And when we think of the reason that many of us might participate in physical activity and exercise, one of them is usually because we want to lead long, productive lives. And this is what's considered as wanting to impact our all-cause mortality, which is basically avoiding an untimely death or premature death. Now, your textbook defines all-cause mortality as dying earlier than the average age of death for a specific population group from any cause. And the research that you see here on this particular slide shows how much physical activity per week can actually reduce your risk of all-cause mortality. What's interesting to note is that even moderate intensities can have a substantial impact on lowering your chances of an untimely premature death. And if you look at this particular slide, you can see that only a few lifestyle choices have as large an effect on mortality as physical activity. Look at the numbers that you see here. People who are physically active 7 hours a week have almost a 40% lower risk of dying early than those who are active less than 30 minutes a week. If any of you youngsters out there have considered, what your life will be like beyond college, beyond your 20s and 30s, or if you are watching your parents and how they're living right now, or the status of their health right now. Some of us might be wondering how we can lead better lives to maybe prevent developing issues that maybe our family members have who have died before us. And one of the ways that we can control that is being physically active. And so that's why you see another valuable statistic is that people that do at least 150 minutes a week of moderate intensity physical activity have a substantial lowered risk of mortality. And I think that's a good message to send home. I think sometimes the general public or maybe individuals that don't necessarily understand how to exercise, let alone, how much they should exercise, have this idea that they should be, just dying every single time they leave the gym, when in actuality, that's not necessarily the case, especially when it comes to simply reducing the risk of premature death. So the main message or the main takeaway points from this slide is that we clearly see evidence from research about the importance of being active, and that some physical activity is better than none at all. For those of you that are graphic learners, this slide might help you understand the association between exercise and risk for all-cause mortality. And you'll notice that performing only 60 minutes of moderate to vigorous intensity activity in a week puts you at a greater risk for premature death than if you'd completed more minutes during the week. And then you can see that the risk continues to go down as you increase your number of minutes of physical activity. An important study from 2012 by Moore helped the Physical Activity Guidelines Committee kind of come up with some really important findings. The first one is the beneficial effect of physical activity has no lowest threshold, and that the slope is steepest at the lowest amounts to moderate to vigorous physical activity. And that at least 70% of potential benefit on all-cause mortality is reached by achieving 8.25 Met hours. So that's where we get the 150 minutes a week of moderate to vigorous physical activity. What this committee also found is there's no obvious best amount, but there's also no apparent upper threshold. So when we talk about the fact that they have not found an upper limit in regards to the benefits of physical activity, that's what they mean here. The committee also found that benefits began to accrue as more physical activity is accrued, and activity volumes of up to 4 times the 2008 guidelines of 150 to 300 minutes of moderate to vigorous intensity physical activity show no evidence of increased mortality risk. So some of you might be thinking, okay, well, so what can we actually go out and do if we want to make this positive impact on reducing our chances of all-cause mortality? And the answer, some of you might be thinking this, is simple. It's go out and do some cardiovascular activity. Modalities could be walking, jogging, cycling, swimming, stair climbing, rowing, are all some examples of some cardiovascular activity. A key point in our physical activity is that we must remember to pay attention to intensity during exercise. Remember, this is the key indicator of cardiovascular work. And exercisers who work at moderate to vigorous intensities will be the ones that reduce their chances for all-cause mortality more than those who operate at low intensities. So for those of us or those of you that want to monitor intensity, remember the percentage of heart rate max is it's an affordable way for individuals to track if you were really working at that moderate to vigorous intensity. And remember, a lot of that information is presented in chapter 2, if you'd like to reread some of that information moving forward. And this is another good slide that kind of answers that question, well, what should I do? Now that I understand better about what's important, this is a whole list of different modalities that would be appropriate types of physical activity to reach that minimum requirement. Now that we understand how to reduce risk of premature death with exercise and physical activity, our next 2 slides briefly introduce cardiovascular disease and metabolic syndrome and what these 2 issues have to do with the general public and large groups of Americans. So let's talk about cardiovascular disease first. Lots of different disorders that you can see here in regards to the heart and the blood vessels. We're talking about things like coronary heart disease. We've got cerebrovascular disease, hypertension, peripheral artery disease, rheumatic heart disease, congenital heart disease, heart failure. So lots of different things that can be impacted in regards to not only our circulatory system, our heart as well. Most of the risk factors for any sort of cardiovascular disease are modifiable with physical activity and exercise. And what happens is by by being physically active, we reduce other risk factors of the disease. And by playing a direct role in the physiological changes at the cellular level, as well as in the blood vessels as well. Metabolic syndrome. We're actually going to jump a little bit more deeply into metabolic syndrome, and we'll kind of circle back to cardiovascular disease. So if you haven't heard of metabolic syndrome before, this is a cluster of clinical characteristics, either in adults or in adolescents or in both populations, of the following 4 things that you see here in the middle of slides. So we're talking about being diagnosed as having abnormal blood lipid levels, elevated glucose or maybe insulin levels, maybe previously being diagnosed as hypertensive, and as having excess abdominal obesity. And when you think about these metabolic issues, like having excess fat around our middle or being diagnosed as hypertensive or having high blood pressure, usually An individual that has one of those things typically suffers from a few other issues because again, remember, it mostly stems back to lack of physical activity. And so most organizations would diagnose someone with metabolic syndrome when an individual presents with 3 or more of those above issues that you see on the slide. And when you have an opportunity, click on the YouTube video here. It does a really nice job of laying out. If you're someone that really appreciates graphic layouts or animations to help you learn, I recommend it. I don't show them normally on pre-recordings because in the past I've had issues with the sound coming through. And so instead of you sitting here watching something with no sound, this is embedded into your PowerPoint. So just take an opportunity to do that after you listen to lecture. Okay, so now that you've had an opportunity to watch that video, what you can see here again are what doctors typically use to diagnose someone as having metabolic syndrome. And again, it's if they present with at least 3 of the risk factors that you see here. And remember, it might seem easy to self-diagnose yourself or to maybe know that a parent or maybe a family or a family member or a sibling has a couple of the factors here. It is very important to make sure that you consult with a physician if you think you may be an individual or a family member might be suffering from metabolic syndrome. And so you can see the prevalence and the economic costs associated with metabolic disease in this country. Look at these numbers, they're pretty staggering. Over 1 billion people globally have the cluster of factors. And we're talking about 422 million worldwide have diabetes. You can see that the prevalence of the metabolic syndrome varies, but we do know that it's estimated that between 23 to about 34% of the population right here in the United States has metabolic syndrome. And so we do know that sometimes these estimates vary based on genetics, age, ethnicity, things of that nature. So we can see that it's a pretty global issue as well as a very large issue right here within the United States. And you can see that in 2015, about 10% of the population was estimated to have type 1 diabetes or type 2, which is most of the cases that are diagnosed right here in this country. And we know that people with diabetes are at very high risk for developing heart disease, as well as suffering from some sort of stroke. And we also know that individuals with diabetes are likely down the line, if it's not medicated or addressed by physical activity, diet, and exercise, that blindness can result. There can also be issues with kidney and kidney failure, as well as lower limb amputations. So you can see that even though we have individuals that are walking around maybe with some excess fat mass, combined with hypertension and possibly having diabetes, you can see the result of chronic excess weight. As a result, we're talking about an increase in all-cause mortality. You can see the change on this slide from the diabetes prevalence starting back from 1994, where we see less than about 4% of the population suffering from diabetes, all the way now till 2015, where we're talking about greater than about 9% of the population. And granted, this was 6 years ago, so I can only imagine how much more red would be prevalent on this particular slide. So if you're someone that's curious, if you want to know more, maybe a visit with your physician would be a good idea in order to maybe fight an official diagnosis of metabolic syndrome. Usually physicians will offer up exercise and diet as the first 2 recommendations. Obviously, it depends on other health markers. Pharmaceutical intervention may also be a part of the equation if the physician is really concerned, or maybe if the individual has other accompanying health issues. So remember, when an individual presents with usually about at least, with about 3 of these items that you see here, abnormal levels of lipids, so blood lipids, elevated glucose, hypertension, or excess of abdominal obesity. Exercise is usually recommended. And then you can see that the information on this slide shows how physical activity and exercise fights these risk factors, therefore fighting metabolic syndrome. So if you're concerned about the risk factors for maybe yourself, like I said, or even for a friend or a family member, then it really is important to see your physician. And at your appointment, a physician can use clinical measures to gather your health numbers. So height, weight, heart rate, blood pressure, BMI, body fat percent, waist circumference, as well as have you participate in either a fasting or a non-fasted glucose test. And with these results and these health numbers, your physician can begin to determine if you are indeed at risk for metabolic syndrome, as well as any other health conditions like maybe cardiovascular disease, as well as how to take control of your health. In a fasting plasma glucose test, your blood glucose is measured after an 8-hour fast. And if your glucose level is 99 milligrams per deciliter or below, then the test is considered normal. If a glucose level of 100 to 125 is found, that's consistent with prediabetes or impaired fasting glucose, which means a person with these levels is at higher risk for type 2 diabetes. If the level is 126 or higher, then the person is diagnosed as having diabetes. There's also an oral glucose tolerance test where blood glucose is measured after an 8-hour fast and then 2 hours after ingesting 75 grams of glucose dissolved in water. It's yucky, it doesn't taste good, and you have to sit around the doctor's office for quite some time in order to get your results. But then you can see the numbers. So when we talk about a glucose level of 139 or below, the test is normal. A glucose level between 140 to 199 is consistent with prediabetes. And if the level is over 200, then the person is clinically diagnosed as having diabetes. There's also a third test called a random plasma glucose test. And this is measuring blood glucose in a non-fasted state. And this is when a person has diabetic symptoms. So those are things like increased urination, increased thirst, unexplained weight loss, maybe fatigue or blurred vision, or maybe increased hunger or possibly having sores that don't heal. And again, if the glucose level is above 200, then the person probably has diabetes. A lot of times clinicians prefer the fasting plasma glucose because it's convenient and inexpensive, but the oral glucose tolerance test is more sensitive for diagnosing prediabetes, and this is also how gestational diabetes is also usually diagnosed as well. So you heard me rattling off some numbers just a second ago, and this would probably be a good slide to show you now. So this shows what a physician or a doctor may use to officially diagnose an individual as having or not having metabolic syndrome according to your health numbers specifically. So this is for, it can be for, you can see here, fasting glucose, blood pressure, cholesterol, so blood lipids, triglycerides, as well as abdominal obesity. And if you look on your annotated PowerPoint that I provided for you in the module, on this slide in the notes, you have a linked web address that takes you to the ACSM's website where it talks about taking waist circumference measurements. And so take an opportunity to click on that. It's a great tool. It teaches you how to take waist circumference. And remember, like I said, you know, some of these heart rate numbers, some of these health numbers can be seemingly easy to take yourself. And that's good information to know, but it's also important that if you are concerned or feel that you have several symptoms, that you, again, see a physician so you can have something on record with your doctor so there's a plan of attack moving forward for you. So the research on this slide is from the U.S. Department of Health and Human Services, as well as the committee that created the physical activity guidelines. And what it does is illustrate a relationship between the risks of having metabolic syndrome and the amount of self-reported physical activity or exercise. And what we can take away from this research is that metabolic syndrome risk drops dramatically even with moderate amounts of physical activity and exercise. This is a similar study, again, from the Department of Health and the research committee for the physical activity guidelines, backing up the idea that metabolic syndrome drops dramatically with moderate fitness levels for adults. The risk of developing syndrome drops dramatically with moderate fitness levels of adults. So again, the value in this is not only just to see how physical activity can reduce the development risk, but also the fact that we don't have to be killing ourselves in the gym, killing ourselves outside. We're talking about moderate activity and fitness levels can have make a big difference. So, what recommendations are there in regards to protecting your metabolic health? This slide does a good job of explaining the recommendations and probably would be a good slide to know for the exam. And your book does a really nice job of talking about a diabetes prevention program. Take an opportunity to read through that. It's good news for individuals specifically who have been diagnosed with pre-diabetes or type 2 diabetes. But these are the recommendations that you see here. And again, this is the first bullet point is from the previous slide and the previous research. The risk for developing metabolic syndrome drops with moderate amounts of exercise. Halsey, which is mentioned several times in this particular chapter, talks about the fact that exercise deficiency is a serious public health problem because of the fact that without exercise, we're talking about the development of the chronic diseases and an accelerated decline and this is the important takeaway from this point, an accelerated decline in the function of skeletal muscle, cardiovascular, and metabolic functional capacities with aging. So the aging is something we are all going to be a part of. We are all aging now currently. And so when we're talking about decreasing the risk, not only for all-cause mortality, but staving off the development of these metabolic issues and diseases, we need to address exercise deficiency. And so this is the slide that kind of backs up what the scientific evidence says about physical activity and metabolic health. And again, I would know this for your exam, for exam 2. So we talk about the fact that there is strong evidence that regular exercise improves metabolic health by 30 to 40% over that of sedentary individuals. And that is true for men, women, as well as various racial and ethnic groups. So it's standard across the board for all of us. And there's limited evidence on daily bouts and reduced risk of metabolic health issues. There's more evidence looking at long-term data. And so here's the recommended dose. We're talking about a minimum of 120 to 150 minutes a week of that moderate intensity, or vigorous would be great too. Any activity below 120 minutes, we see that risk for metabolic conditions go up. And what we do know also that we'll touch upon here in a little bit as well is that resistance training is extremely effective in improving glucose control in the body. And so resistance training is recommended in addition to simply just performing any sort of cardiovascular activity. And again, that's why our physical activity guidelines talks about the importance of not only being aerobically active, but anaerobically active as well. I think it's important to present some research in association with the information that we're learning in this particular chapter when it comes to cardiorespiratory metabolic health. And so what I've done for you is I've linked for you 4 particular research studies that talk about how physical activity impacts not only metabolic syndrome, but symptoms of metabolic syndrome, right? So hypertension, extra abdominal obesity, things of that nature. And so instead of me really going over those in detail for you, part of your work for this week is to click on the links on each of these four different pieces of research. So the first one is presented to you here. It's by Laura Christ and colleagues. The next one is looking at Lackinson, talking about low levels of leisure time physical activity. So when we're talking about leisure time physical activity for this particular article, we're talking about things that people choose to do in their free time. And then we've got another article on childhood obesity predicts adult metabolic syndrome. And then we have another study by Morrison looking at metabolic syndrome in childhood predicts adult metabolic syndrome later in life. And so the reason that I'm simply presenting these articles to you now instead of really going over them in depth is because I want you to take some time this week to do the research, read some of these papers, not necessarily all of them, every single page, but use your research skills to look for the questions that are posed to you in the annotated PowerPoint. So these questions are asking you to identify who the participants are. What was their average age? How many participants were there? And did anybody drop out of the study? So the first question that I want you to research about these four different articles really is about the study participants and be able to explain who they were for each of these four articles. The next thing I want you to research then are what were the interventions for each of the articles? In other words, what were the participants being asked to do? Were they split into groups? Were they being asked to diet? Were they being asked to exercise? What was being measured? Were they given something specific that they needed to do by the research team? Look at the groups that got the intervention versus maybe possibly having some sort of control group. And so once you really understand what the research asked the participants to do or maybe not to do, look for a hypothesis. What did the researchers think was going to happen as a result of that intervention? What were the results? What happened? Were there differences between the groups? And what kind of conclusions can be made from the results of the study, as well as looking for and interpreting how this relates to what we're learning for this particular class. So take time to look for those answers in each of these four articles. They are linked for you, so you shouldn't have to go to Google Scholar at all by yourself. You should literally just be able to click on each of them within the PowerPoint. And they are also free, so you should be accessing the entire length of the articles for free. And if you have any questions accessing these articles, let me know. So for individuals that are actually fighting metabolic syndrome, we know that doctors would diagnose some sort of exercise guidelines. And it would be beneficial for those individuals to probably have a certified professional that knows how to deal with a special population like metabolic disease or possibly someone that has type 1 diabetes. If it's not possible to find a personal trainer for this type of special population, then we would recommend that someone who is new to exercise would start slow and then work up to some sort of demanding programming. The goal is to be active as many days as possible via a modality that is enjoyable for the individual. For example, if someone liked to walk, then their goal would be to walk every day. Vice versa, if they like to swim, then they should be swimming every day. A key part in making a lifestyle change, in changing one's behavior, is to make sure that they enjoy what they're doing. And that kind of helps them be less likely to repeat any poor behaviors that they had maybe been a part of their routine. So enjoyment is truly a key in beginning any sort of exercise program, but also when we're talking about impacting some lifelong behaviors. And remember, we want to stick to the basic exercise principles of the physical activity guidelines here. We're incorporating aerobic activity in a method or a modality that's enjoyable to the participant. And we're talking about resistance training. So using maybe simple body weight exercises or machines, maybe free weights or bands, and for them to stretch regularly. And here's some more guidelines in regards to resistance training. We want also, and I think we went over this when we had our first unit before the first exam, understanding how to program resistance training. So when we have novice individuals that maybe don't have as much experience in lifting weights, what we're looking to do is to truly target whole body every 48 hours or so, looking to keep our sets between 2 to 3 and our range of 8 to 12 reps, again, using large multi-joint exercises. So what we're doing is we're moving lots of different parts and pieces of the body in one particular task, and that can help cut down on the total volume that these individuals are having to do. Because what we don't want is someone that's new to exercise spending lots and lots of time, hours in the gym. What we're going to see is burnout pretty quick. So that's why it's a good idea to utilize large multi-joint exercises. At keeping the lower intensity for the beginners, and we also want to incorporate stretching because range of motion can be sometimes problematic in diabetics. And again, we're looking at 1 or 2 stretches per muscle group held for at least, I would say, 20 to 30 seconds. And if we have an individual that sticks with it and they are successful in moving more and sitting less, what we're going to see here are some benefits to regular exercise and physical activity. These aren't anything that we haven't studied before. You know, we see the body that adapts, and we see the health benefits come because of that regular participation. So you've seen these benefits before. We're talking about increasing total energy expenditure, which means we're expending more calories. We have an improved protein synthesis rate and amino acid uptake in the skeletal muscle. We're seeing our blood lipids improves, and we're seeing an improved glucose tolerance, which means we're not in a state of hyperglycemia, and that's a very good thing. Now, I will say this, while exercise is extremely important and recommended by physicians at every health and wellness professional organization, we do need to take some exercise precautions because individuals who have been diagnosed with metabolic syndrome and or diabetes, they are considered a special population due to specific medical needs that change the way that they prepare as well as participate and recover from physical activity and exercise. So this is a key reason why this population is encouraged to seek a certified personal trainer who has specialized training in metabolic syndrome or cardiovascular diseases. And it's important that those with metabolic issues follow the guidelines and for you to know the guidelines in the next 2 slides to ensure safe participation so we don't have someone that decides to drop out and all of a sudden stop moving again. So we do want medical clearance for individuals, especially if they have any sort of comorbidities, and it may be necessary for them to have a medically supervised fitness test prior to initiation of some sort of physical activity. Specifically in individuals with diabetes, blood glucose needs to be monitored regularly. So we're talking about, looking at their glucose levels not only before, but as well as after exercise. And if we see that their glucose is above 200, we need to avoid exercise until that blood glucose level comes back down. We can make an exception if the urine ketone bodies are absent, and in that case, we are allowed to do some sort of light to moderate exercise. And on the opposite end of that spectrum, if blood glucose levels are below 100, we need to get them to eat something to the tune of either 20 to 30 grams of carbs in order to see that number go back up. And we would do that by doing another glucose check prior to initiating any sort of physical activity. And we do need to be aware of dehydration. So we always want someone who's diabetic to make sure that they have water on them at all times during physical activity. Some more exercise precautions, because sometimes we will have diabetic exercisers who also suffer from retinopathy, which means they have increased blurredness. We want to try to avoid large increases in blood pressure that could be caused by vigorous exercise because of the pressure placed on the eye because of that increased pressure. So We might want someone, a diabetic that's suffering from retinopathy, to participate in some more moderate intensity exercises until maybe they are more comfortable or their doctor has cleared them for vigorous exercise intensities. And again, you've heard me say this before, but right off the bat, if you have, if you're a personal trainer and someone comes to you and in their medical history, they reveal that they have any sort of autonomic neuropathy, kidney disease, or a peripheral artery disease, or peripheral neuropathy, those individuals need to be referred to a medically supervised program without question. But if you have someone that you feel that you're certified to work with, we're aware of the comorbidities, we're aware of their medical history. There needs to be a lot of communication about how they're feeling during exercise, and have a good plan of attack and plan for exercise based on those individuals, their goals, and their medical needs. So diabetes is also something that's one of those indicators that could be a part of being diagnosed as having metabolic syndrome. And diabetes is a major health issue. It arises from metabolic disorders. Oh, excuse me. I had a brain fart there. And when we're speaking right now, about diabetes mellitus, there's two types, right? So that we have type 1 and type 2. Type 1 is an autoimmune disease in which the pancreatic beta cells are gradually destroyed. We don't really get into pre-gestational diabetes that's related to pregnancy within this particular presentation. Type 2 diabetes mellitus is a disease that's characterized by insulin resistance or underproduction of insulin, which prevents adequate control of blood glucose. And this leads eventually to hyperglycemia and lots of other complications that come with it. So this is the disease that's really going to be discussed in relation to the metabolic and cardiovascular issues we're covering in this particular lecture. So let's talk more about the differences between type 2 and type 1. But I want to first present how a normal pancreas should function within a healthy person. So when we eat foods, our bodies process the macronutrients in order to release energy and nutrients to the body. Carbs are specifically processed into glucose molecules that are then absorbed by the cells lining the small intestine. And when the glucose-rich blood travels to the pancreas, we have the beta cells in the pancreas detect these rising glucose levels in the blood, and then they release insulin into the bloodstream to transport glucose to the cell. So you have this transport system through our veins and the arteries taking the glucose to the cell, and then we have the insulin that's kind of following along behind it. Once at the cell, then, the insulin helps glucose get into the cell by binding receptors on the cell in a sort of lock and key mechanism. And once that occurs, we've got transport channels on the cell that open, and glucose can now go through those channels in order to be used in producing energy for the human body. But if this process isn't allowed to happen, if we cannot get glucose into the cell, then we have some serious issues that arrive within the human body relatively quickly. So let's talk about type 1 diabetes first. Type 1 diabetes is usually found in adolescent populations, and it truly only accounts for only a small percentage of the overall cases of diabetes. The link on this slide that you can see here is an excellent link. It's a computer animation that shows you a short video of a normal pancreas functioning and then what happens when the glucose can't enter the cell. And what we see is hyperglycemia happens, and then eventually ketoacidosis can occur if we have too much glucose within our blood. And what happens then is we begin to use proteins and fats as energy sources. And the symptoms that's occurring are things like dry mouth, nausea, abdominal pain, muscle weakness, shortness of breath, and even mental confusion. A lot of clinicians have said or maybe described someone as having a diabetic issue as acting as if they were drunk. And I think that's kind of reflective of the mental confusion that's listed for you here. But again, if you like computer animation, take time to click on this video. It does a really nice job of showing you what happens when we can't get that glucose into the cell. Now, the other diabetes disease is type 2, and this is the type of disease that arises in adults that make poor lifestyle choices, who lead sedentary lives, and then are linked to metabolic and CVD issues that we talked about in this chapter. Usually individuals who suffer from type 2 diabetes also have, again, those comorbidities, high blood lipid issues, high BMI, hypertension, so that's, high blood pressure, and then all those other metabolic characteristics that we've talked to that are linked to metabolic syndrome. And so you can see here, again, we kind of mentioned them before, but there was a bunch of different other assessments for metabolic disease. What you see on this particular slide is the graph of the classification for diabetes. These are easy numbers to memorize. There's actually a game within your module that helps you play around with remembering these numbers. It helps you study. So be sure to know the fasting blood and random glucose levels that would classify someone as normal, pre-diabetic, or diabetic. You probably have a very simple, easy test question on those numbers. And again, I've also given you another video to understand or to watch about type 2 diabetics. And so in order to classify yourself, obviously there's that simple blood test that can be done in a doctor or physician's office. So if you have any of the risk factors, and I'll actually pull these up right now, you probably want to make a visit with your physician, just so you can, like I said, so you have an answer, and so there's an official medical supervision, supervised plan of attack in the event that maybe you are diagnosed as pre-diabetic or diabetic. Here are the risk factors. So here is what puts someone at risk for developing usually type 2 diabetes. So if you have a family history, if your ethnicity or race, Hispanics, African Americans, Asians, Native Americans are at higher risk, if you lead a sedentary lifestyle, or if you have a history of CVD, these are risk factors that would indicate that you might want to go see a doctor to check things out. But you can see that these factors are closely related, and physical activity and exercise play a very important role in the prevention and treatment of these types of issues. The next slide that I have for you, I think, is a great resource. Thought I hyperlinked it, but maybe I didn't. This is actually taken right off the CDC's website that provides some more information. I thought it was very interesting. I thought it was relevant because it absolutely is evidence-based, research-based, and maybe it would be a tool that you could utilize with maybe a family member, somebody that's close to you, to get them thinking more about what they do and if they might be at risk for diabetes. Same with this one, another resource directly off the CDC that I thought might be useful for you. So if you're concerned you might have some of the risk factors that have been presented to you so far in this chapter, we do know research shows exercise and physical activity are key ways to lower your risk of developing specifically type 2 diabetes. And you can see the research on this particular slide shows that the risk for the development of type 2 diabetes is significantly reduced with regular bouts of moderate intensity physical activity. And this is because of the metabolic adaptations made as a result of physical activity. Again, we see an increased total energy expenditure, so that helps maintain an energy balance. We see an improved protein synthesis rate and uptake into the skeletal muscle. We see reduced low density lipoprotein levels and triglyceride levels, but an increased high density lipoprotein levels. So that's good. We want high numbers of HDLs. Those are the good cholesterol we want in our blood. And then also improved glucose tolerance. So if you haven't heard me say it yet, even only moderate activity can be crucial in preventing the development of your chronic conditions. So I told you we would circle back to this, and here we are. We're actually going to end with talking about cardiovascular disease because we introduced metabolic syndrome and metabolic health issues first because CVD seems to arise in conjunction with the presence of these metabolic risk factors like poor blood lipids, elevated glucose levels, hypertension, things like that. So the following slides are going to introduce us to the basics of CVD, and let's start by talking about the prevalence. Again, the statistics kind of speak for themselves. It is the #1 cause of death globally right now. You can see that about 7 million of these deaths were with heart disease, 6.15 million was associated with stroke. And what we're talking about is a monumental shift away from infectious diseases as being those major killers towards chronic or non-communicable diseases as leading cause of death worldwide, which is interesting because if we're talking about the fact that we have, for the most part, modern medicine just to stave off infectious disease, you'd think we'd be set, right? But this is how much of a killer sedentary behavior really is. And you can see the economic costs associated with the prevalence of CVD. We're talking about billions and billions of dollars associated with individuals having these issues. Here are your modifiable versus non-modifiable risk factors. Know those. And again, here are the benefits of being physically active. So you as pre-practitioners in this class, getting ready to go out into your physical therapy office, your occupational therapy office, your strength and conditioning, gyms and labs, you should be able to explain these common changes that can occur following participation in regular, personalized physical activity and exercise programs. So you've seen these before, memorize them, know them. And if you actually take a second to look at this next slide, I like this slide a little bit better because what it does is break the benefits down into the physiological, biomechanical, and behavioral benefits associated with physical activity and exercise. So know these, be able to recite them. This is stuff that you should have learned in previous classes that hopefully is just something that you've seen again, that's brought back up again, that is like second nature to you. If you have a difficult time explaining the health benefit, the physiological, biomechanical, and behavior health benefits of exercise, it's not good. We'll just say that. Be able to say things like, I know that exercise causes a lower heart rate. It causes my resting heart rate to drop. It lowers my blood pressure. It improves, my ventilatory fatigue. So there's an improved way that I'm able to move. I have better balance and coordination. All of these things need to be known by exercise science students going out the door at graduation. So know this, you will absolutely see test questions on this particular slide. So let's talk about an important indicator of cardiorespiratory health. And we talk about VO2 max, which is what some of the research on this slide is talking. So it's showing a person's maximal, cardiorespiratory endurance, as well as the body's ability to extract more oxygen for muscle activity. And there are ways to estimate someone's VO2 max, and we talk about the Fick equation, F-I-C-K. Now, this formula shows the pump function of the heart as well as muscle function. Both of these components adapt specifically due to exercise and provides increases in cardiorespiratory capacity after conditioning. Now, this means a person's VO2 max will improve after consistent training, which you can see here in the graph above. And what you can see depicts significant increases in VO2 max after 1 year of exercise training in an untrained individual. So if you wanted to use a Fick equation, it's laid out for you in your textbook, but its VO2 max is a multiplication problem where you take your max heart rate multiplied by your stroke volume multiplied by the AVO2 difference. And so the following components are indicative of pump function of the heart. So when you're able to look at maximum heart rate and stroke volume, that tells us the pump function of the heart. And then the AVO2 difference shows us muscle functioning. So the muscular adaptations of the increasing oxygen extraction. So the reason that I bring up the Fick equation is because it's important in understanding, again, the pump function of the heart as well as the muscle function, because different types of physical activity affect different parts of the circulatory system. Some people may not be able to strengthen their heart as much as they can improve their peripheral circulation and therefore improve their health. However, a healthy person should see both improved pump function via increases in stroke volume and improved peripheral function via increases in the AVO2 difference. When we talk about learning cardiorespiratory health benefits from physical activity, it is important to note that maximum heart rate for individuals typically stays the same and may decrease slightly for most individuals with training. This is a direct result of the increases seen in stroke volume, where the heart has more time to fill, thus sending more oxygen-rich blood to the working muscle. So when we talk about this opportunity for the chamber to fill, we're talking about seconds of a second pause where there's an increased fill in blood volume, which gets then pumped out to the rest of the body and eventually to the working muscle. So we see on this particular slide, research from Kinney, Wilmore, and Costill, actually relatively recently, 2020, that represent the changes in stroke volume for elite individuals. Most individual stroke volume will increase over time with training, and then it will plateau at a certain point of an exercise workload. However, the participants of this particular study have the genetic ability for stroke volume to continue to increase with exercise workload. And possible explanation for that is because this particular research was done with elite level individuals. We have another study from the same researchers that shows significant changes in heart rate after exercise training, utilizing 3 different training modalities of walking, jogging, and running. And so the value, the importance of this study, it supports the body's physiological adaptation of lower resting heart rate from physical activity and exercise. When discussing secondary prevention of CVC, we talk about how the American Heart Association, the American College of Cardiology, all recommend the clinical practice of cardiac patients attending cardiopulmonary rehabilitation programs after experiencing a cardiac event. So if you've ever heard of cardiac rehab, sometimes it's simply just cardiac rehab. Sometimes it's a facility that does cardiopulmonary rehabilitation. And we also have hospital clinics that do simple pulmonary rehabilitation separately. And these are all medically supervised programs for individuals that have had some sort of heart or lung issue that need to get back into exercise or that need to learn how to exercise for the first time to prevent a second event from happening. So most cardiopulmonary rehab units or facilities utilize 3 different phases of training. Usually phase 1 is an acute inpatient training where the individual may still be in a hospital bed, and it's simply education-based, telling them about the importance of physical activity, explaining that they're going to be in cardiac rehab, and what's going to happen when they actually are able to get out of bed and go to this rehabilitation program. The phase 2 I was going to say the phase 2 phase. The phase 2 component of cardiac rehab is outpatient, where an individual will actually come to the facility. They'll be medically supervised with an exercise program for about 4 weeks. Most of the physical activity that they are performing are aerobic in nature. So they will do some sort of treadmill walking, maybe an upper body ergometer where their arms are simply moving, or maybe they're on some sort of recumbent bike. But again, it's medically supervised, usually with an exercise physiologist or appropriately trained nurses to make sure they aren't having any sort of cardiac episode during training. And then if a client has, continued to attend, or they've graduated, they haven't dropped out of their outpatient phase 2, then they would enter phase 3, where they no longer have to come to the facility for training, but they are coming back and maybe being medically supervised one-on-one with a personal trainer that is from the cardiac rehab unit that will work them through an exercise program that the individual can eventually perform on their own. So it's very structured from the time an event happens, maybe even as soon as them being in the hospital, getting ready for discharge, and then, in a specific facility with specific guidance and oversight, to then slowly phasing them out to learning the skills to be physically active on their own, either at home or in a gym setting. And with cardiac pulmonary rehabilitation programs, research has shown that compliance in these types of programs significantly reduces cardiac events by 20%, as well as cardiac mortality by 26%. So if any of you have interest in being an exercise physiologist, you definitely have a great career in front of you in a cardiopulmonary rehabilitation center, either at a clinic or with a hospital usually. So how are we going to assess someone's cardiorespiratory fitness? The best way really is to assess and classify it just like we would assess someone's body fat percentage or maybe one's body mass index. And in order to do so, we can use a prediction equation with maybe the results from an in-field test, or we can use clinical measures to acquire maybe one's VO2 max or VO2 peak. Assessments require either maximal or submaximal work levels and are appropriate for various individuals depending on the reason for assessment. So if we're looking to evaluate an athlete versus someone that's maybe had a cardiac event, we would choose assessments based on the individual, absolutely 100%. And there are lots of different types of cardiac fitness assessments out there. And so the first one we kind of talk about is VO2 peak. And this is the highest oxygen uptake value or workload obtained without achieving a true maximal criteria, and it provides an estimate of aerobic power. Now, VO2 max is the maximal ability of the body to use oxygen to produce energy for performing work, and is an estimate of aerobic power and is related to aerobic capacity. Most exercise physiologists consider the VO2 max as the single best predictor of cardiorespiratory fitness and function. The most common assessment is usually a graded exercise test on a treadmill. Now, let's talk about maximal testing. Remember when we just said that choosing the appropriate fitness assessment is absolutely about the individual. And so when we consider maximal testing, it is truly only recommended for a low risk or individual or maybe youth population like an athlete. And that's because we don't ever need to max out someone with comorbidities or someone that's even an older adult. We don't need to do that. But if you do have an athlete, if you do have someone that's relatively young and they need to have some sort of fitness assessment, submaximal testing is typically used with other types of populations. But again, it varies depending on the need for the assessment. So you'll have a soccer athlete that will complete the yo-yo intermittent recovery test during their season, while you might see older populations that might just do a simple step test or maybe a 1 mile walk test. And your book does a good job of talking about which populations should avoid submaximal tests. So be sure to read that pretty clearly in your book. Right here in the UCF Power Lab, We've got a lot of research projects that require VO2 max as a part of the data collection process for some of the studies that we do here on campus. And what we see is study participants will put on a mask and they'll put on a backpack called a portable metabolic analyzer, and it reads their gas exchange and shows their VO2 max based on the physical activity or exercise performed. So it's actually pretty cool. But again, the assessment depends on the individual. And what does the scientific evidence say for aerobic activity? Back in 2008, we've got our physical activity committee that gave us strong evidence. So they said there was strong scientific evidence supporting an inverse relationship between the volume of exercise and incidences of CVD. And what they found is that regular exercise improves cardiorespiratory fitness and lowers the risk for CVD, heart disease, and stroke by anywhere from 20 to 35%. Guys, that's a lot. The benefits also apply equally for both men and women of all ages. Again, does not discriminate between gender, racial, and ethnic groups. And the committee since reviews 10 years of scientific evidence and literature and provides more precise health recommendations. And these findings are briefly mentioned above on the slide, but make sure that you read them a little bit more in depth in your book. All right, ladies and gentlemen, at that point, this is the end of lecture. If you need anything, please get a hold of me, and I hope this was helpful for you too. Have a great week.